I think, ma'am, we can start now. Okay. So a very good evening to one and all present here. It gives me great pride and honor to initiate this session today. I'm Dr. Molina Patel, consultant from Akansha Hospital and Research Institute, Anand, Gujarat. And today we have a very interesting session lined up for all our viewers. We all know that lifestyle disorders are very common in our day-to-day practice, mainly diabetes, hypothyroidism being some of the most common ones that we encountered on the day-to-day basis. So today, as a part of Women's Day celebration, we decided to join hands with experts in order to put light on practical aspects of how to deal with these issues. Let me take this opportunity to welcome, first of all, Dr. Nayana Patel, Medical Director of Akansha Hospital and Research Institute. Ma'am needs no introduction. She is world-renowned. Joining her today, we have Dr. Dhruvi Hasnani, ma'am. She is endocrinologist as well as medical director of Rudraksha Institute of Medical Sciences in Ahmedabad. And Sir Dr. Vipul Chavda, sir. He is also medical director of RIMS Institute, Ahmedabad. Both Dr. Dhruvi Hasnani, ma'am, and Vipul, sir, are renowned diabetologists practicing in RIMS Institute in Ahmedabad. Without much delay, I would like to welcome you all, sir and ma'am, for this session. So today we have, certain interesting topics and interesting questions that are, that lots of people ask us on our day-to-day practice. To begin with, my first question is to Dr. Nayana Patel, ma'am, that, we all know endocrine conditions are very common in everybody's OPD, whether it's an orthopedician or it's a family practitioner or it's a gynecologist. So as an IVF practitioner, practicing infertility day in and day out, how many, what proportion of your OPD patients account for patients with diabetes and other endocrine conditions?
Thank you, Molina. Welcome all the doctors. So I would say that infertility and endocrinology go hand in glove. There are so many patients who have subtle subclinical diabetes and subclinical hypothyroidism, and that could be actually the reason which is not giving them a pregnancy or resulting in a miscarriage. So simple treating that even subclinical deficiency or hyper state could treat the patient, prevent miscarriage, and she can conceive faster. So as of now, I would say that because of the lifestyle changes or stress or whatever it is, or we are aware and we do a lot of checkup, we find a reasonable number. I would say if I'm seeing 10 infertile patients a day, at least 3 to 4 will have some hypothyroid issue, and in about 25, I would be seeing one patient who is borderline diabetes.
Yes, that is very true. It is very more common than one would think. But as soon as such patients come to our OPD and we refer them to an endocrinologist or a family physician, the first question that they ask us is, do we really need to go? Do we really need to start medicines? We are very scared of insulin. Thyroid medications we will have to take lifelong. So my next question is to Vipul, sir, that do all the conditions need medications always? If not, how apart from medications can we deal with these issues?
Good evening, everybody. It's my privilege to share the screen with one of the biggest, I would say, celebrity of our medical field, Dr. Nayana ma'am, and Dr. Dhruvi and Dr. Molina. So most of the time we overemphasize on pharmacotherapy. Most of the time we need to understand what is underlying cause. We have to investigate it condition very properly. And if we are treating the root cause, like when there is a overweight, when there is a sedentary lifestyle, when there is some behavioral disorder is there, we should improvise there. And once we are correcting the lifestyle and still there is underlying cause, we must try the pharmacotherapy. But in this today's era, when non-communicable disease are taking head over the communicable disease, and we are suffering from more lifestyle disorder than infectious disorder, a change in the lifestyle, change in the behavioral therapy would be a choice of therapy for most of our patients.
That is also true, sir. And I think also, after COVID, again, the management has also changed in that aspect also. Like post-COVID, patients have become more sensitive towards their own issues as well. So this was, related to our infertility practice. But I'm sure, sir, that you and Dhruvi ma'am are seeing a lot of patients of pure endocrine conditions. So, ma'am, in your practice, what is the proportion of patients who come with these endocrinal conditions, like mainly diabetes, hypothyroidism, and who are trying to conceive?
Well, good evening, everyone, once again, and welcome to our very special program with Nayana ma'am, Dr. Molina, and Dr. Vipul. So, like you rightly pointed out, we are seeing a rising prevalence in all of these metabolic disorders across the spectrum. And the latest guidelines and the latest consensus which has come out says that above the age of 35, 7 out of 10 people, adults, have metabolic syndrome. And that is one of the biggest reasons why the prevalence of diabetes, type 2 diabetes per se, is increasing. When we talk about females coming to us with the metabolic syndrome, underlying diabetes or subclinical hypothyroidism, the prevalence is, again, like Pam said, we are seeing 1 out of 25 with a pre-diabetes condition, and say 4 to 5 out of 10 with a subclinical hypothyroid or thyroid disorders who are unable to conceive. So that's the prevalence. But one has to be concerned now that the actual population who should be targeted are the adolescent girls, the teenagers who are, I feel, more exposed to the environment and the epigenetic factors these days, and are coming to us with menstrual disorders, who are coming to us with PCOS, and coming to us with obesity. All of these are pre-diabetic conditions. And these are again going to lead to troubles with fertility, troubles with conceiving naturally. So I guess this is the alarming data that all of us are facing and all of us are seeing in our day-to-day practice.
That is true, ma'am. Excuse me. Also, ma'am, how strong, what is the role of genetics when it comes to these conditions? Because we know that whenever even we take a simple medical history, family history is very important. We always ask whether your parents are diabetics or whether you had brothers or sisters who had diabetes in their pregnancy. So what is the role of genetic predisposition in developing these conditions?
This is one of the most interesting questions that we always have. And we as Southeast Asians are one of the susceptible ethnicities for having type 2 diabetes and for having metabolic syndrome as well as obesity. And if you all know that there is something known as the YY paradox, that in comparison to the Caucasian population, we Indians have at a smaller BMI, we have larger fat mass that puts us at a higher risk for insulin resistance, which puts us at a higher risk for early onset of not just diabetes, but metabolic syndrome, dyslipidemia, hypertension, and cardiovascular disorders. So genetics do play a very, very important role. And it's along with these genetics, there are epigenetic factors these days, which have really put us into place and tried to emphasize on the lifestyle modification as one of the very important modalities for management of all of these endocrine as well as infertility disorders that we are seeing.
And ma'am, quickly, like just major 3 or 4 disorders, on your fingertips, if you could count for us, with women attending the infertility OPD should be watchful about.
All right, should I take it up?
Yes.
Yes. All right.
This is actually for Dr. Dhruvi, ma'am, because I think she's the expert, for this question particularly.
So the first thing is PCOS. Second is type 2 diabetes. Third are thyroid disorders. These are the frequency and the prevalence amongst women attending infertility OPD and coming with endocrinological disorders that we are seeing. And another important thing is obesity, which we do not, we are not proactive about. So obesity is one big risk factors that females coming to our OPD do not address, and we as doctors are also very complacent about it. So obesity, PCOS, like I just changed my sequence with obesity being the number 1, then PCOS, then diabetes, and then thyroid disorders.
As far as ma'am PCOS is concerned, there is lean PCOS as well as obese PCOS. So we have also seen in our practice that the lean PCO patients are very, very lean, thin. They are probably underweight or in the normal BMI. still they are having menstrual disorder, menstrual irregularity, still they are having long-standing infertility, and still they ask us, that what we should eat, what precautions we should take. So ma'am, just a few quick tips about management of lean PCOS.
The first modality for treatment of PCOS, whether it is lean or obese, is lifestyle modification, which consists of diet as well as exercise. So diet plays a very, very important role, and not all of us are, again, very proactive about teaching our people with PCOS or women with PCOS about what are the dietary intervention they should take. Reduction in the amount of carbs, increase in the amount of proteins have shown fantastic results with girls with PCOS and with women with PCOS. That is number one. And exercise, again, is something that we should not neglect. Even girls who are lean, even women who are lean should exercise, should pursue muscle strengthening exercises to improve their muscle content and reduce their fat content. In spite of being lean, these are the women with a higher fat percentage that leads to insulin resistance, which leads to a disbalance amongst their FSH and LH levels and leads to hyperandrogenism. But this can be encountered by very simple lifestyle modification that can be taken in smaller steps and can be pursued very well with lean PCOS girls.
Very, very properly and very nicely explained, ma'am. So my next question is to Dr. Nayana, ma'am. When a patient comes to her for the first time in the infertility OPD, what panel of investigations do you first, advise to them? Mainly, we all know we do TSH for this. So what is the target levels of TSH? If it is high, what advice would she like to give for such patients?
So first of all, I would like to reiterate the fact that now we see more endocrinal problems because now the couples are coming late in the age group. Previously, by 25, they would have finished their obstetric career. So male and female now 30 plus, 35 plus are very common. And when they come to us, minimum we have a thyroid examination for the female, prolactin level we have for the female, in the endocrinological part, FSH, LH definitely, and AMH. And when they are like near menopausal age, even estradiol, or when they look PC or hyperandrogenic, we do the testosterone levels and the 17-alpha hydroxyprogesterone, all these levels. For the male also, at least a sugar level is a must. And if there are azoospermia or obstructive azoospermia, then the other hormones. And we also do test for some males TSH levels. But normally we have diagnosed diabetes for the first time in an infertile male who has come and says everything is normal, but we have diagnosed diabetes in them. So when they come for IVF treatment or any infertility, we diagnose diabetes for them because they've never checked their sugars, the male part, and they feel that it's only the female who could have hormonal problems. But male problem also with high sugar levels is immense, obesity is immense, and the men also need to correct their endocrinal profile before they start or when they are embarking on the starting a pregnancy. It's not only the female, it's also the male. Now, the thyroid levels is what they say that preconception, it should be 2.5, first trimester 2.5 TSH, then second could be 3, third could be 3.5. But recently when I attended a webinar, a conference in Thailand, there was a group from Denmark and they come up with a new guidelines, very new, which is still not implemented, but they said that they want the TSH to be 4 because if you keep it very, very low and keep supplementing the female with a lot of thyroxine, that also will have a negative impact on the fetus. And you can see very many fetus when the thyroxine T4 level free, etc. are high because you are trying to control that TSH level, they can have many neurological issues. That is the latest what I have heard. But so far we keep it at 2.5, 3, 3.5, and preconception we try to bring it down. So that is one. Sugars, definitely HbA1c is the best parameter. Whatever said and done, I would want it less than 6.5. But if a very, very diabetic woman is coming to us, I can go up to 7.2, but that is also high. And in the male also, I would like to bring it down to 6.5 HbA1c before we start the treatment.
Okay, ma'am. Also, ma'am, we know that when a pregnant lady or a lady trying to conceive, comes to us, we always want to treat her in combination with an endocrinologist. So, Dhruvi ma'am and Vipul sir, do all the patients need to come to you as well all the time? What is the frequency of visits that a patient should come to an endocrinologist while they are pregnant and with some endocrinal condition?
Our first advice, Dr. Molina, is always about preconception care. A lady, even if she is, planning to conceive naturally, we would say if not an endocrinologist, at least go to a physician to get your routine body analysis done. And preconception care is again something our emphasis always lies upon. Like ma'am said, that a lot of females undergo so much of undiagnosed subclinical thyroid disorders, which is very common in India. Anemia is another thing which these females should be looking to correct before conceiving. And if we talk about diabetes, then any woman with pre-existing diabetes, we always ask her that 3 months prior to conceiving or prior to getting pregnant, we advise that she should be on insulin with a stable dose of blood sugar levels continuously. And the targets for HbA1c for her are like, again, ma'am has already said it has to be below 6. And it can be very well managed these days with technology, with the use of pumps, with the use of continuous glucose monitoring. It's very easy. After that, in accordance with the visits to the gynecologist, we can either do a teleconsult visits every month, or we ask her to drop down physically to the clinic at the change of the trimester. But it's very important and pertinent that her sugar levels be monitored all through this time, either through a televisit a technological process, or through WhatsApp. A simple WhatsApp would also do, or a physical visit once in 2 months or once as the trimester changes.
Okay, ma'am. The next question, ma'am, is, diet. Diet has a major role in how even the medicines influence the disease, and it influences independently the disease itself. So what dietary precautions do you advise for your patients while they are pregnant, or when they are trying to conceive, or for somebody who is overweight? So it's very vague, but just few general tips that could cater to mainly common endocrine conditions.
All right. Small frequent meals are something we advise for females who are diabetic, and for females, who want to keep their sugars well under control. Intake of a lot of water. Calories, whatever calories she takes, have to go through proteins and simple carbohydrates, which can be managed well. Something very important is monitoring, which we forget to tell these females. This is the time when they are most adherent to any advice that you give. In terms of monitoring of their sugars, in terms of what to eat, how much to eat, and some simple exercises also, upper body exercises are what we suggest. Some simple walking for a couple of minutes, regular puja exercises also could be nice. Kya puja karte ho, niche baith jao, ya phir kuch, some small light upper body exercises are good for these females. Diet plays a very important role, like you said. And for this, we ask their mother-in-laws and their mothers to come down to us, because these are the ladies who have to be counseled upon that you don't give them any heavy sugared sweets, and a lot of ghee and all those things are not healthy for the baby as well as for the mothers. So a family counseling is necessary when we want to teach them about a healthy diet during the time of pregnancy.
Yes, that is very true, ma'am, because I think diet also is influenced by cultural norms and festivals in our country. So there's always defaulting, and that also can influence the levels. The next question, ma'am, is that many a times we come to know that, diabetes, when we even ask the patients in their history that, हमें तो old age का diabetes आया है, या फिर हमें वो मेरे मदर को भी 50+ आया था, so ये तो is very normal thing for them. So many a times diabetes surfaces in their late 40s or late 50s, and that is also a category of women that we see, that is mainly the menopausal women. So, ma'am, is there any particular age from which we should be more careful?
Dr. Molina ma'am, the latest guidelines are saying that everybody above the age of 30 have to be screened for diabetes in India. And a simple random blood sugar should be sufficient for screening. But when these sugar levels are crossing the impaired fasting glucose levels or impaired postprandial glucose levels, we have to go for an HbA1c. So what we say, if you have say a family history, there is a Indian diabetes risk score which is there, and you can just Google it up for everybody who's listening. You have to put in your family history, you have to put in your waist circumference, you have to put in your age, and you have to put in the type of lifestyle you are having, whether sedentary, whether moderate, active, or heavy exercises or something like that. So it gives you a score as to what is the probability of you getting diabetes in the next 5 to 10 years. So in spite of all of this, if you are an Indian, you are at a moderate risk of having diabetes after 30 years of age, and every year get an HbA1c done. Simple, that would be sufficient enough. So all these postmenopausal women are our high-risk patients, whether or not they have a family history.
Yes, that is very true, ma'am. In fact, there was a statistics in this Diwali itself that India is the highest consumer of sweets all over the world, and it crossed all the records in October itself. There was this very interesting survey which I read in Times of India. So on a lighter note, weight loss has always been an issue with most of the patients. And I think weight again is a very important factor in the control of all these conditions. So Vipul sir, very quickly, a few tips. When you're trying to deal with a patient and instruct him or her to lose weight or to get into a normal BMI.
Yeah, weight is the one of the very important thing for the management of many non-communicable disease. And to lose weight is very difficult. And again, patient tends to regain the weight. And it is observed in a recent study that diabetic patients are going to lose weight in a lesser speed as compared to non-diabetic, but their speed of regain is more than of the non-diabetics. So it is always difficult to lose weight. A simple tip that they can do in their day-to-day life is, first of all, a behavioral changes. Sometimes as more screen time, more sitting and eating regularly by either Zomato or any other food will increase their weight. Second important thing is they should increase their water intake. We forget to drink water. Even our doctors or my friends, we discuss that they are not drinking enough water. So decrease the screen time, decrease binge eating, increase your water intake, some behavioral therapy in terms of exercise. And if you are in office, you can do a stretching even in your office chair as well. So some basic changes in our day-to-day life will increase our ability to reduce the weight and also to not regain the weight.
Yes, and I think every 30 minutes also they recommend that you should just move about, take a walk. We all have smart watches now to even keep a track on the number of steps that we take daily. Just a quick tip or a few words on the nature of exercises, because most of the pregnant ladies who have specially conceived with IVF, they are carrying twins or they have some bleeds. So we tell them to exercise or to do some light activity, but then they are also very scared that will it affect the pregnancy adversely. But then say, for example, if she's a diabetic, so in such a tight situation, how do you advise her that what is normal level of activity for her?
Yeah, exercise level is different for every individual. For non-pregnant lady or non-pregnant person, we will advise that not only stretching is sufficient. They have to do some weight training to reduce their weight and maintain their muscle mass. But when a patient is pregnant or carrying a twin pregnancy, then we will say that normal walking is advised, and some kind of stretching which do not involve abs or abdominal muscle, they are advised for them.
Okay. Also, ma'am, this is the next question is to Dr. Dhruvi, ma'am. Do you have some common myths or some absolutely wrong mental blockages that patients have when it comes to dealing with diabetes? Like I have, for me personally, I came across a patient who said that, insulin lahi hai, to we become extremely fat. and then we have to take it lifelong, and it is very harmful for the body. So that was a very, very important thing that I want to put light on in this for all the viewers, that even in the management of such absolutely strict conditions, we know insulin is for diabetes, we know thyronorm is for hypothyroidism, yet people have mental blockages. So what is your comment on this?
Number one, insulin is a life-saving hormone. So if you are prescribed insulin, we must not stop it until and all the diabetologist or an endocrinologist or a physician tells you to do so. Number two, insulin is not addictive. So once you put on insulin for a certain number of reasons, you may be withdrawn out of that insulin once your target sugars are achieved, or you're off the steroid medication, or once you deliver the child. For somebody with a good reserve of beta cells in the body, so somebody who is having type 2 diabetes, that person with a good C-peptide level, with a good natural insulin reserve, is given only temporary insulin therapy to get their sugars within a target range along with the medications. But for somebody with type 1 diabetes, insulin is forever, and insulin is a life-saving agent for all these people living with type 1 diabetes. So the myth that insulin once taken can never be withdrawn is untrue for somebody with type 2, but for a type 1 person, insulin is a life. So unless and all without a recommendation of your doctor, please do not withdraw your insulin levels. Number two, like you said, insulin does lead to a little bit of weight gain. Again, because insulin is a growth, a hormone which takes care of all the metabolism in your body. And number two, when your sugars get under control, of course, it will lead to a little bit of weight gain. But it's been evident through various data that it does not lead to a weight gain of more than 4 to 5 kgs. So that's all right.
Okay,
that's number one myth.
Very interesting facts. Yes, sorry, ma'am, please go ahead.
No, so sorry. One another interesting myth that we hear is, jaundice hua tha, the doctor gave me a DNS saline pine, and after that I got diabetes, or after that I got diagnosed with sugars, which is absolutely absurd. It's not because of some treatment, or not because that you are eating sweets, or not because you are having some sort of food that you are becoming a person with diabetes. It is because your metabolism is not producing sufficient amount of insulin to metabolize the food that you're eating. That is why your sugar levels are higher. That is why you're becoming hyperglycemic. The latest data says that there is not just type 1 and there's not just type 2. We have the LADA type, we have the monogenic diabetes, and we have a number of other classification of diabetes in these days. The most important thing is that a person with any sort of diabetes should request his or her doctor to get his insulin reserves checked to find out what sort of a diabetes he or she is having. And it is 2023. We also have genetic analysis. And I'm aware that we at Akansha Hospital are doing a lot of genetic analysis for different sorts of diabetes. And I think that should be one way forward for people with diabetes to understand the exact kind of diabetes they have. And it's the time and era of precision medicine. And we have to, give this option to everybody with diabetes to understand that we have the precision medicine. We also have perfect pharmacotherapy for the perfect sort of diagnosis with diabetes.
That is very true, ma'am. And that is where I think the role of specialists like you come into play. Ma'am, I have one personal question. How are diabetes and gut microflora linked? Because we all know that almost all diseases are postulated to originate from the gut. True. So I'm sure that diabetes, being a metabolic disease, also has some link to the gut. So what is your opinion on this?
It has a huge link. It has an established link now. A lot of our pharmacotherapies that we are giving are targeting the gut microbiota. And in fact, we are doing one huge whole conference that is just targeting about various sessions on gut microbiota and diabetes. So a change in the gut microbiota leads to what we now call it changes in the leptin-ghrelin axis and change in the GIP and GLP-1 axis of the gut-brain barrier. And all of these disbalance leads to some sort of beta cell dysfunction, leads to, changes in the gluconeogenesis, and diabetes per se is a multifactorial or multipathophysiological disease. It's not just the insulin production that has troubles, which leads to hyperglycemia, but a lot of other factors like troubles in your peripheral absorption or receptors because they are not able to work with your insulin production, troubles with your gut microbiota, like you said, that leads to hyperglycemia, trouble with the liver, trouble with the brain. Now we have the type 3 diabetes also along with dementia and Alzheimer's, and a lot of other pathophysiologies. Now we have, again, like I said, a very novel molecule, the oral semaglutide, which is targeting all of these therapies. And we are going back to our roots where our Indian science was also saying that every disease starts from the gut. And the allopathy and evidence-based medicine is also saying the same, that if your gut microbiota is good, you will have no diseases, and everything starts from the center of the body, that's the guts.
Yes, ma'am. And I think even we at our institute, we have already conducted a study proving this, that there is a direct link of the gut microbiota as in certain conditions like PCOS and recurrent pregnancy loss. So I would just like to briefly have Dr. Nayana to have her opinion on this.
Yes, it is very important what you eat, because it's our Ayurveda also saying that Amma is responsible for everything. And we had proved that in 11 fertile women, we compared the gut microbiota with the 10 recurrent implantation failure patient and 10 unexplained infertility. And we could find that the gut microbiota, that is the bacteria which is the Prevotella, should be present in the female, because it causes a mucin lining and prevents the leakage of the gut and prevents inflammation of the endometrium, whereas the other Hagatella and bacteroidetes are very bad. So we have done this initial study and we have published it, and later on maybe the probiotic, the diet changes, as you said, you emphasize on the greens and the proteins, and carbs should be good quality but bare minimum, and fat also good quality fat should be included in the diet. The combination should be taken right, what protein with what carb. That is also very important. Along with it, exercise and when to eat your meals, 6 frequent meals, but before 7 in the evening, you should have it. All these things are very, very important.
Yes, I would like to add also one point, that not only management of the disease, the gut microbiota helps, but condition like diabetes, the inflammation or microinflammation leads to many complications. And if you have a good gut microbiota, the long chain fatty acid available in the distant colon, they lead to increase in the microinflammation. And because of that, there is a lesser chance of complication, either in form of neuropathy, nephropathy, retinopathy. They all are lesser in a good microbiota having patients.
Correct. Very true, sir. So I think we have covered quite a lot in a very small, time regarding mainly hypothyroidism and diabetes, and some common, very superficial yet commonly encountered questions. I would like to conclude today's session because this topic is endless, and every week, very often, more often than not, we will be taking different aspects of these endocrinal conditions and discussing them in detail. But thank you very much, Dhruvi ma'am, Vipul sir, and Nayana ma'am for this wonderful session and for sparing time. I would like to also just emphasize if there are any more questions in the chat box, but there aren't any, which brings to my question. I just have one very quick question, ma'am. So this is mainly for Dhruvi ma'am, that we see nowadays lots of pharma companies, they are coming up with these protein powders and diabetic friendly protein powders, which are meal replacements. So, they say that you skip a meal, but you have this particular protein and it will metabolize, it will balance your sugars, it will help you lose weight, your PCOS will go in time. So they have 90 days programs in which they have meal replacement packets available. So, ma'am, what is this? It totally is against what we have been eating and what our grandparents have been eating, but what is your comment on this?
All right, very quickly, I'll say that these are not natural and these are not practical to be taken for a longer period of time. When we are asking a lady with PCOS or a girl with PCOS to undergo all of these changes for a period of 90 days, it's not sufficient and it's not enough. Some practical changes in her lifestyle, in her own diet that can be done and that can be followed, say for her lifetime, are what is advised instead of these supplements. They are not bad. I'm not against them. We prescribe it to people who are not able to take the sufficient amount of protein in their own diet. But whatever you take naturally through food, through your own meals and through your own diet, through the natural things that the God has given, that is the most beneficial thing rather than these supplements. That's the gist of it.
Okay, thank you, ma'am. Thank you so much for your answer. So I think, ma'am, there aren't any more questions in the chat box. If anybody in the audience has any questions, you can please ask.
So I think let's take this opportunity to wish everybody a happy Women's Day in advance to all of us and to all those listening. Every day is a Women's Day, but we have something special to celebrate, and I think that's a reason that we are celebrating all the women at Akansha as well as at RIMS. And tomorrow is also World Obesity Day. So a word for all the women to take care of themselves first and at least put themselves at some level of priority instead of, just shaking them off at the end.
Yes, thank you, ma'am, for those last two important words. Thank you, ma'am. Thank you, sir.
Thank you.
Thank you.
Thank you, Nayana, ma'am. Thank you, Dr. Molina, and thank you to our all audiences for joining.
Thank you. Thank you.
Thank you.